It's a pleasure to be here. It's a pleasure to see some of you who I've known for a long time, which is great. Just a little bit of housekeeping. We would like to hold questions until the end of the session, and we will have plenty of time for those sessions. I am chairing a panel of two people who I go back with for many, many years. And the first of our speakers is Dr. Peter Phillips, who I know since he was a fellow at Memorial Sloan Kettering Cancer Center. We were both about 14 years old, Peter, right? You were 13, yeah. And so we do share a history of working with kids with cancer, developing treatment and treatment protocols, and looking at now as the treatments that were developed were successful, now looking at what did these treatments do? What did this disease do? So I think we have a really great session set up, and I'm going to introduce Peter first.
Look, I know you know this, but pediatric tumors are not simply small adult brain tumors. Okay, that the concept of the homunculus, that is the little old person in a baby's body, which was so common in the 17th and 18th century, it doesn't work for brain tumors. We see different types of tumors. We see different frequencies with which the tumors come up, not the least of which is that childhood brain tumors, as you know, are less common than adult brain tumors. We see different responses in terms of how the tumors look at and get smaller with treatment. And a lot of what I'm going to talk about today, we often see for the same histological tumor type, looks the same under the microscope, we see a different genomic profile. So this reminds you that the pie in childhood brain tumors is cut thinly. Unlike adult brain tumors in which malignant gliomas, which are glioblastomas and anaplastic astrocytomas, represent 2/3 of all tumors, and therefore the simple majority. We don't have a simple majority, okay? That we have cerebellar astrocytomas and other astrocytomas being a large component, and for the malignant tumors, medulloblastomas being a large component, but we don't see a tumor type that represents 50%. And if adults are seeing 14,000 to 15,000 new brain tumors a year, and we're seeing somewhere between 3,000 and 3,500 per year, and you cut the pie small, you get the idea of where we are. We also have, fortunately, and this keeps me going emotionally much more than in the adult world, we have a huge range of outcomes. Going from situations like germinomas, in which I've never lost a patient with a germinoma, ever, okay, to brainstem gliomas, in which I've never cured one. The experience in this kind of situation, the physical experience, the neurological experience, and the emotional experience runs this entire gamut in terms of survival rates. We are at a critical juncture here, and I'm going to talk about this several times, but the role of genomics is going to play an increasingly important and major role in how we do things. And I want to separate marketing in genomics from reality in genomics. And I'm hoping that by the end of the time that we talk today, you'll understand what the potential for this is, but where we are right now. So what are we looking at with respect to genomics? When we're talking about genomics, we're looking at what is the DNA, what are the mutations, What are the areas which are overexpressed? What about the RNA? What about changes to the DNA by adding other chemicals to them that may alter regulation? These all in the field of genomics, but basically where we're talking right now, for this purpose right now, is going to be about DNA. So we're looking at the question of why did a tumor happen? How did it come up? Okay? We're getting information about that through genomics. Treatment. Are there opportunities now that genomics, that is, understanding the DNA of a tumor, are going to help us in terms of developing better therapies? Prognosis. You've heard today an eloquent talk about you don't treat all tumors the same way. And remember, for those of you who were looking at infant brain tumors, we've been taking care of infant brain tumors as if they're just put in the bag and it doesn't matter what the histology is. We need to understand how we can tailor the intensity of a treatment better by prognosis. And then risk. Risk is an issue of, is there something about your general DNA all through all the cells in your body that may tell us something about either the risk that you may have for further tumors or risks of other people in your family. I'm going to start with the back end here and say this is an issue that we can talk about in more detail, but we know that there are a whole group of situations in which the genomic information is informing us. Neurofibromatosis type 1, neurofibromatosis type 2. These are specific genetic mutations. Li-Fraumeni syndrome, which you probably have heard about, is a situation in which the P53 protein, P53 location is mutated. And it makes it more likely that you will generate other kinds of tumors. Gorlin syndrome, a situation which predisposes to medulloblastoma, tuberous sclerosis, other kinds of tumors. All of these have genetic profiles. And how we define a family's risk and how we define a patient's risk is coming up more and more as we understand what the specific mutations are and how they may help us predict this. The biggest thing I want to leave you with, I'm not finished, but I want to get started and I want to finish it with, is an understanding that for 50 years, easily, DNA has been our single target, okay? Our only target. DNA is the target for radiation therapy. DNA is a target for Cytoxan, for cisplatinum, for carboplatinum, for VP16, for 5-fluorouracil. All the drugs for methotrexate, all the drugs that we've been using for the last 50 years have focused on one area. And we've made progress on this based on the fact that it's fairly easy ultimately to do various permutations and combinations of drugs, not really knowing what you're doing, but just kind of guessing. And that's what we've been doing, guessing. Well, we can't do that anymore. We can't do that anymore because the world is much more complex. So let's start with a couple of examples of where genomics is informing us. Brainstem glioma. This is the tumor type which is among the most dreaded that we experience. It's one in which I can say with confidence that we have not made significant progress in my lifetime with this tumor. And it's one in which it's extremely difficult to understand what's going on and what the targets could be. We know the question of whether we should be biopsying these tumors or not biopsying these tumors is a very complicated one, based on the fact that we don't have an effective therapy that if we biopsy it, we're going to know what we should be doing. So right now, our standard therapies for diffuse intrinsic pontine gliomas is radiation therapy plus research, okay? And there's lots of research that's been going on about it, but we still have yet to make a dent in this. The survival rate is low, you know that. But there is a glimmer of hope with a number of institutions that have found the same genetic finding, not in the majority, or not in every one of these tumors, but in a substantial number of these tumors. And without getting too far into the details of the science, there are changes within a kind of a protein that is regulating how DNA is expressed. It's called a histone protein, histone H3, and mutations in this are now being found as being fairly characteristic of patients with diffuse intrinsic brainstem gliomas. So a change in histone 3, the F3A locus, is found in 60% of the DIPGs that were looked at. All total, more than 78% of the ones that Susie Baker looked at St. Jude have this mutation. That's an exciting finding because we didn't have a single clue to go on with this tumor up till this point. And this has been repeated now with three different other institutions. So we know about this protein in terms of some of the things that it can do. We know some of the ways that it works. I'm sorry. There. But what we don't know is we don't know a drug that works on this, and we don't know a mechanism to make use of this. So this is the beginning of the kind of the unraveling of the yarn that's going to be necessary. But at least we have a beginning, because before that, we were guessing. Ependymomas. Ependymomas are in pretty much the same situation as it relates to a target, but the outcomes for ependymomas are substantially better than they are for brainstem gliomas. Thank God. Ependymomas, if you have an extensive resection, do well, generally. Biopsy alone do poorly. And some of the ones that are well differentiated do better than those which are anaplastic. And I think you've heard that before. And most of our current therapy is gated towards whether or not it's either well differentiated or anaplastic, whether it's totally resected, GTR, or subtotally resected, STR, or metastatic. So we have different therapeutic strategies based on different clinical situations. The objective is to move that to a situation in which we can either identify who we should be treating more aggressively with a more reliable indicator, and then hopefully one in which we can find a target. So in this kind of situation, we know that we have information that copy number, the gain of copy number on the chromosome 1 predicts a poor outcome. It may be the case that finding this in a patient who has a gross total resection and a supratentorial tumor is going to mean maybe we should be treating this patient more aggressively than simply watching. So this is a prognosis issue, but what we don't have for ependymoma is we don't have the correlation of genomic findings with a new target yet. Low-grade astro is a different story, and this is a story which has been to a certain extent in the last decade driven heavily by the patient community and their funding and research for this. So low-grade astrocytomas, up till about a decade ago, we really couldn't find any significant genetic abnormalities associated with this. And we have a variety of chemotherapy strategies for these, ranging from carboplatin and vincristine all the way down to some newer agents, including RADO01, as well as the MEK inhibitors. So we have some potentially effective therapies, but nothing that's a knockout. One of the areas that we're making significant progress in is an understanding that the BRAF gene, B-RAF, can hold some clues to which treatment type we should be using. And this is a schema that indicates that BRAF mutations, either the V600E mutation, which you see at the top, or the KB mutation, which you see off to the side, may participate in the cascade that's necessary to form a tumor, and particularly in neurofibromatosis, we know this to be true. We know that these different kind of mutations occur at different rates in terms of different kinds of astrocytomas. So JPAs often have a BK fusion mutation. PXAs, which are pleomorphic xanthoastrocytoma, I dare you say that 3 times in the morning before you have coffee. Pleomorphic xanthoastrocytomas, most of them have V600 mutations. But what this means is that mutations of the V600 pathway are likely to respond to certain kinds of treatment strategies that are targeting this pathway, and that if you use the wrong one, you may make it worse. Or if you have a KB protein, fusion protein, using the wrong target may make it worse. So we are in the process right now of making certain that we understand what the status of each and every one of these patients with low-grade astrocytomas is as it relates to the BRAF protein. And we expect to find others as we dig deeper into this. And finally, I think the biggest story is medulloblastoma. And most of you know that this is a tumor which is among the most aggressive that we encounter. It has a high rate of metastasis at the time of diagnosis, not the majority, but still a significant minority. And that for years we've been using clinical staging criteria to determine how we're going to treat these. So if you're young, if your tumor's out of the posterior fossa, if you have a lot of tumor left over and metastases, that's a high-risk patient. That we have looked at, many people have looked at the gene expression profile with medulloblastoma, and there are things coming out of it that are informative and being acted on. This is a very dense slide, but the gestalt about this that you should have is that right now, on a consensus basis, there are at least 4 groups determined genetically for medulloblastoma. There is the WNT or Wnt pathway group, which looks like it responds very well to a variety of existing treatments and may be a target or maybe a candidate for either really cutting back radiation therapy or not doing radiation therapy at all, and that's part of a research study. SHH, sonic hedgehog. This is a group of tumors in which there is a mutation in sonic hedgehog, or the patch mutation. This is the tumor type that we see in Gorlin syndrome. And there is now a specific target for sonic hedgehog pathway mutations that is extremely effective. Group 3 and Group 4 are more of a collection, one of which is extremely aggressive, and that is particularly Group 3. And this is a group that we need to be treating as aggressively as possible, but we don't have a target yet. The medulloblastoma sonic hedgehog group, this is a very exciting area for us. We know that in this kind of situation, comparing normals, which you see off to the side, and animals that develop tumors that don't have any drug, getting drug that is the hedgehog inhibitor will move it to a point in which you can't see tumor left over. And in this publication of a patient in New England Journal back in 2007, these were the metastases all over his body prior to treatment with GDC 0449, which is the hedgehog inhibitor. This is what it looked like 2 months later. The black below is his bladder. The black above is his stomach. The black in the middle are his normal kidney collecting structures. So practically nothing can we see. Unfortunately, the body and the tumors figure out a way pretty quickly to get around this. but the ability to use this in select patients who have this target to accomplish very rapid tumor decrease in size is substantial and very exciting. So look, I want to end with an understanding that right now we've gone about as far as we can go with standard chemotherapy that targets DNA. We are at a point in which we need to be moving from DNA as a target to a whole bevy of different targets. But unlike guessing about one type, specifically DNA, we can't guess about 50 types. We need to focus in, and the information that's going to allow us to focus in comes from genomics. We are doing this through the Children's Brain Tumor Tissue Consortium, in which we're collecting tissue, we are developing models, and we are doing full genome sequencing that will be available to any investigator throughout the world. Ultimately, our objective is to have a targeted therapeutic strategy. Thanks. I do. Are we going to do questions at the very end?
At the end.
Okay. Okay. I have another talk. I am talking today for some colleagues of mine who are in the Society for the, SIOP, which is the International Pediatric Oncology Society meetings. And so Dr. Hill, Kaiser, and Dr. Lustig, who are our radiation therapists, and the focus of our efforts in terms of proton, can't be here, so I'm pitch hitting for them. There we go. Okay. Look, you know that there are three main ways of treating tumors: surgery, radiation therapy, they're not here, and chemotherapy. I've done surgery and I've done radiation therapy, as well as on rats. I don't do surgery on humans or radiation therapy on humans. But as a neuro-oncologist with a fusion name, we all have to learn about these issues. Our focus today is on radiation therapy, and the idea behind it is pretty straightforward. We are targeting DNA. We're targeting DNA in a way that ionizing radiation breaks apart oxygen into a free radical, and that free radical causes breakage that attaches to the DNA and causes breakage in the DNA chain. And it works because the tumors have less of an ability to respond to this, or to repair it, than our normal cells. So how do we use radiation therapy to improve survival outcomes, meaning how many people survive, as well as quality of survival? Well, the first is we want to avoid it, okay? And realize that in our patient population, particularly in young children with a developing central nervous system, they are particularly susceptible to the damage of normal tissue, damage of normal tissue by radiation therapy. So avoiding it is one situation that we would like to get to. But if we can't, can we modify the dose? Can we decrease the dose? We're doing that with medulloblastoma, okay? We've gone down, over the course of 30 years, we've gone down from 3,600 craniospinal down to as low as 1,800 craniospinal. And we may be able to define patients who are going to be effectively treated without radiation therapy, with only chemotherapy, which, for all intents and purposes, does not result in the same kind of damage to the central nervous system that we see with radiation therapy. Can we modify the volume so that the amount of radiation, the amount of brain that's exposed to radiation therapy is diminished? Can we increase the effectiveness of the radiation therapy? And essentially individualize the dosing and strategy here based on a particular patient's individual risk. So I think you need to understand that as it relates to proton radiation therapy, Proton radiation therapy uses ionizing radiation, okay? Same as standard photon radiation therapy. But protons are heavy and positively charged particles, and therefore they stop in tissue. And this is a complex slide to understand, but the basis of it is that standard photon radiation therapy exposes the entire area, the path of its radiation, all the way through the brain till it gets to the tumor. Proton radiation therapy has a peak, which you can see off to your right. That peak, referred to as the Bragg peak, allows us to place that deposition of radiation therapy strategically and to substantially decrease the amount of radiation to the surrounding local brain. And so this is a schema. Essentially, the tumor volume needs to get 100%, but what we want to shoot for, no pun intended, is to get almost nothing to the rest of the brain. So this is a comparison of protons versus standard photons, and protons are on the right, and everything, on the left, and photons are on the right, and the tumor is getting 100% of the radiation dose. But everything that is in green or light blue is up in the 50% of the radiation dose range. And you can see that virtually the entire brain is getting upwards of 50% of this patient's effective dose. And if you're giving 5,400 centigrade under those circumstances, you're getting a substantial amount to normal brain. By comparison, the protons on the left, you're getting a substantially less amount of radiation. The whole area that's gray is completely unradiated, and the areas that are lavender are down at the 25% range. Or if we look at the way we used to treat patients when Anita and I were taking care of patients at Sloan Kettering, in which we would do it from both sides as a square. Almost the entire brain was getting upwards of 75% of the dose. Using intensity modulated, or IMRT, photons, you can get the tumor area at 100%, but some of the normal brain is now getting nothing. Now look what happens with protons. In this kind of situation, all of the red is tumor. The blue is down in the region of 40 to 50%, and you have a huge amount of brain that's not getting radiated. This extends beyond just the brain. If you're radiating the spine, it means that the heart and the lungs are not getting radiated. And if the patient is going to survive their tumor, it means that they're not going to be plagued by cardiac problems throughout the rest of their lives. Our clinical uses as it stands right now emphasize posterior fossa tumors in infants and young children, and these are situations in which we can now safely radiate. When I say safely, I'm using that in quotes here. I'm saying it not in a point of causing severe cognitive damage, but safely radiate infants and young children without exposure to the normal thinking portions of the brain on a large basis. Supracellular tumors like craniopharyngiomas are very much a perfect tumor type for proton radiation therapy. A variety of low-grade and high-grade supratentorial tumors, as well as the craniospinal radiation that I just showed you. It's a big deal to put together a proton facility, and it took about a year and a half of construction. This facility has some unique capabilities, and this is not, full disclosure, I make no money from this. I'm not supported by the proton radiation therapy facility. However, I can tell you that the specifics of this machine allow for a beam shaping that is unique among proton machines now, as well as what's referred to as pencil beam therapy, in which there is a radiation beam that's scanned across and stops at very irregular margins, in which you can get even less of the normal brain exposed. We'll move on. That essentially, we know that radiation therapy is still an important part of what we do. We want to make it as safe as we possibly can. I think it's critical to leave here with an understanding that proton radiation therapy, as it stands right now, is not going to cure more tumors, cure more children of their tumors than intensity modulated radiation therapy or other forms of photon radiation therapy. But what it has a substantially higher chance of doing is leaving those survivors with functionally intact cognition, a lower risk of secondary tumors, a lower risk of stroke or other vascular problems, and a lower risk of dementia. And I'm going to save questions for the very end, but I thank you for your attention. And next is...
Thank you, Peter. It is a pleasure to introduce Dr. Jay Storm, who is the Leslie N. Sutton Chair of the Division of Neurosurgery at the Children's Hospital of Philadelphia. Although I've not met Dr. Storm before today, I did know Dr. Sutton, whom he has a chair, which is really exciting. He's a graduate of the Johns Hopkins University School of Medicine, completed his residency in neurosurgery and fellowship in both neurosurgery and neuro-oncology research at Johns Hopkins, and a fellowship in pediatric neurosurgery at the Children's Hospital of Philadelphia, where he stayed. He is internationally recognized for his research and surgical treatment of brain and spinal tumors, a leader in endoscopic skull-based surgery and complex reconstructive surgery. His lab has received over $7 million in NIH grants. Our tax dollars at work go into something really good. Foundation grants and philanthropic donations. He's authored more than 100 publications, including articles in Science, Nature, and the Proceedings of the National Academy of Sciences. Dr. Storm.
Thank you very much for inviting me here to speak with you this morning. As you heard Dr. Phillips talk about, the real key is better understanding of the genetics and ways that we can treat these. But it does start with surgery, and there's a clear correlation between getting more tumor out and handing the patient over to Dr. Phillips and his team, or all the oncologists, when you have less disease. In fact, a lot of the tumors, fortunately, if we remove completely, are cured. Unfortunately, too many of them, even when we remove them completely, are not cured. And one of the things that, and to get to that goal of resecting as much tumor as possible without hurting the patient, has been the development of intraoperative MRI techniques. Every tumor, even diffuse intrinsic pontine glioma, the surgeon can take it out. The question is, what are you going to be left with once you're done? I mean, you cannot survive if you remove the pons. Other tumors that are curable are in locations like the hypothalamus or the optic nerve that you just cannot take out completely because the morbidity would be too high. So we try and walk that line of getting as much tumor out without hurting them, and that's been the goal of developing intraoperative MRI. So again, with disclosures, I do not receive any money from any intraoperative MRI companies. And technically, we don't have an intraoperative MRI at CHOP. I mean, we have the capabilities of doing it, and we'll talk about it and explain why we do what we do at the Children's Hospital. But just so you know, any bias towards or against it, or what I think about what we do at CHOP. So this was actually the original, this is the first intraoperative MRI. This is a huge, so here's the table, just to give you an idea of scale. So this is a huge machine that's in the operating room, and it only can do about 0.4 Tesla. So your standard MRI, when you get, as an outpatient, you go to the hospital, get your MRI, you're anywhere between 1.5 Tesla and 3.0 Tesla. So even though this is a huge machine, it doesn't have a very high field magnet to it. But like most things, right, that's how it begins. And then as it's progressed, the low field magnets now have gotten considerably smaller, whereas but we'll talk about some of the advantages and disadvantages. And now we have the ability to do a high field at the same Tesla level that you can get outside of the operating room as well. Oops. So this is now what these low intraoperative MRIs look like. So again, considerably smaller than the original one that was in, I think it was in 1994 up in Boston. And then, so this one you can actually operate in between it. Because it's a lower field, you don't have to worry quite as much about some of the problems with the higher field with instruments when you're working on it. But again, it has some downsides. So the advantages are it's a relatively inexpensive unit. I know more about the cost of the high field, so we'll talk about that. But this is what it's, and these were the first ones. We had one of these actually at Johns Hopkins, and it does not require any major room renovations. In fact, you can use the same rooms that you've used before. You can just roll it in again because it's a low field magnet when it's not on. And you can just keep it in the room or in the side of the room. And it has less time than doing high field MRI. You have to do a lot more precautions with the high field MRI, and it takes longer. There's a learning curve with both, but once you're up and running, it's much quicker with the lower field. So the disadvantage is it's a weaker magnet, so the resolution is going to be much less than it is in a higher field. And again, that all goes back to the images and the sensitivity. If you can't see as well, it's possible that you may leave some tumor behind when, in fact, you've done your intraoperative MR because you can't see it. So to kind of give you some idea, this is a low field scan on the left, and this is a high field on the right of the axial views. And this actually almost looks like a CAT scan. And then this is a sagittal on the low field, and this is a sagittal on the high field. So again, for certain things, if you're looking to see, did you get your catheter in the ventricle or a cyst? This doesn't have a cyst, but if you had a large cyst you're trying to access by placing a catheter, shunt, doing a biopsy, then this is certainly adequate. If there's a subtle change somewhere in the brain, or you right on that margin of where you need to be, maybe you're going to miss it. So how about the high field? Well, again, we saw the resolution, and you can get the same strength. It's very sensitive. It's as sensitive as your regular post-op MR because it's the same strength magnet. And it can, one of the advantages, which, because these are so expensive, that hospitals have been trying to do is when they're storing the magnet, they'll actually be able to scan patients who are not having surgery when the magnet's not in use for an intraoperative case. So these are extremely expensive. So back in around 2008, CHOP was beginning to build a room for a intraoperative MRI, and it was we were looking at about $10 million to build the room, to protect it, to get the magnet up there. And you can imagine in a pediatric hospital, we probably at CHOP are looking at about somewhere between 100 to 130 tumors a year. And of those, it probably makes sense to do maybe 2 a month. So you're only really looking at about 24 tumors a year that you would be utilizing this. And if you're only I don't know what the reimbursement is, but say it's even $5,000. I mean, you're talking decades before you could ever get that $10 million back. But if it makes it better, then that's why the hospitals are willing to invest that money. And it's also a substantial increase in the operative time, especially in the beginning. And you have to get all new equipment. You have to be very careful because even when this magnet's not on, the power is quite, the magnetic power is quite strong. So basically there are two types out there that you can get, and this is the one that's on a track. So here's the operating room. So you come in, you would do the surgery here. You feel like you're done the case, everything's finished. Now you want to take a look with the intraoperative MRI to make sure you're finished. So then that door will open, and now you can see here's your standard 1.5 Tesla magnet that's on this track. Now it's going to start moving towards you. It's getting closer to the patient, and now the patient's head's in the gantry, and you're able to do your scan. Once the scan's done, then you just move the magnet back. The other option when you build it is to have the magnet stationary, and then you have to actually move the patient. So once you're finished, you then put the patient on the stretcher, the door will open, you'll roll it into the magnet, and then do the case here. So if this were, the way it was initially designed to CHOP, was there was going to be another door here, it was going to be near the elevator, all the ICU patients would be scanned in the scanner when it wasn't in use for the OR, but then when it was when you were going to use it for the OR, obviously it would be closed to them. What ultimately happened in 2008 was the recession, and it got scrapped because obviously, that was some serious money when we were all trying to make sure we could keep providing care to the patients as it was. So this is just the view here, right? So you don't see the tracks now. And the advantage of the tracks also is you can then build maybe 2 other rooms next to it. So you could have 3 rooms, then the 4th would be to do outpatients, and then you could move that into 3 different operating rooms. This one you can move in to anyone, but again, the way it's housed is in this. So you roll the patient in, just do it in the scanner. When you're done, then you leave it. And that's basically what we do at CHOP. The difference is, instead of having it in the room next door, we have our operating rooms on the 4th floor, the magnets on the 3rd floor. When we're finished, we'll actually completely close, which is one of the downsides with these. You don't actually have to completely close. That way, if there is more operating you have to do, you're ready to go. So what we'll do is to completely close it, go down to the scanner, do the MRI with the patient intubated, asleep. If the scan looks good, we go to the ICU and extubate. If not, we bring them back to the operating room. And in discussions moving forward about what's the best thing for us, instead of investing that money up front, it just seemed that it made more sense just to hold that scanner open, even if it meant 2 hours to wait for us to come down. That was probably not only more cost effective, but also safer. You don't worry about instruments getting involved in the magnet because there are no operating instruments down there. The patient's totally closed and you're finished. So there is a real advantage. And again, we didn't have to invest a single penny to do it that way. All we had to do is make sure that everyone on board with radiology and the techs and the anesthesia. And one of the great things about CHOP is, if you have an idea, they might not say yes immediately, but they never say no, and they're willing to hear you out. And basically, the discussions for us to build a formal intraoperative MRI are not going to happen because we've had such good success with the way we've done it. And instead of paying, that's $10 million, we can put towards research, we can put to another program, and use that money. So, again, that's my disclaimer that since we don't have one, take it for what it's worth. That I like our system. So then the also issue is, who needs an intraoperative MRI? Because, if you have it, you might be willing to use it more if it's right next to it, but does everybody necessarily need it? Because again, it does add operative time, and it has risks to it. I mean, there are reports all the time of instruments that are getting sucked into the magnet, oxygen tanks. I mean, it only takes one mistake, and it can be a catastrophic problem. So for me, when I look at a patient, I'll look at the type of, I want to know where's the lesion, and if there's a natural boundary between where that lesion is, even if it's next to a very critical structure, then I don't think we really need to do the intraoperative MRI, because when I see that structure, I know that the tumor's out. But if there's no boundary there, then I want to know. Are they near eloquent areas? And again, it's a tumor that's not going to be easily separated from normal brain to abnormal brain. the higher grade tumors are much different than normal tissue. It's your lower grades that as you're transitioning from that kind of low grade tumor moving into normal brain that boundary gets very blurred. And then some small lesions that they're just so small that you're worried you're going to miss them altogether, then you're going to be more apt to want to get a scan before you hurt somebody. And then again, any kind of these low grade lesions all meeting that same criteria. So I'll just show a few cases to kind of try and illustrate these points. So here's a patient that has a very small lesion near the cavernous sinus. So when I talk about these boundaries, so here's the brainstem. So there's a nice thin layer of arachnoid that separates the brainstem. Here's the optic nerve. Again, these are all areas, the carotid, the middle cerebral artery, the ventricle. There's a tumor abutting the ventricle. Once I get into the ventricle, I know I've taken it out. Once I see this artery or see the third nerve underneath, then I know if there's any tumor in the uncus, it has to be out. So these are all cases that you wouldn't need to do the intraoperative MRI. But this was one I was worried. It was near the cavernous sinus. Here's carotid artery. There are a lot of cranial nerves running to control the movement of the eye there. And it was pretty small, so I was worried that this would be one that either it could be hard to find, or you might get to that boundary and want to know, am I a little high, a little low before I cut into it. And in fact, we got down there were all these nerves. I wasn't exactly sure, so we went down to the MRI. And sure enough, you can see this dot here. So we went underneath the temporal lobe, but here's this dot of air. So that's where I stopped was right on the membrane. So I didn't actually even touch the lesion, but now I know that it's safe to go through there. We brought them back to the operating room, and then we're able to kind of safely move it. And just, I think, safer for the patient, and also just reduces a lot of anxiety in the operating room for the surgeon when you know that you can just run down there real quick, check. Patient never has to wake up. Again, we did have to take the staples out and then start over, but that adds, for the way we do it, we're probably looking at about an extra 20 minutes, because otherwise moving to the stretcher, moving them, putting on the magnet, all that's the same. It's just instead of going 30 feet, we go one floor down. And this is a tumor where low-grade lesion, but there's no real natural boundary here. We're kind of just going into some important structures. And here's the thalamus, here's the internal capsule. So the entire motor is really isolated here. So if you injure that structure there, they're going to be paralyzed face, arm, and leg. I mean, their whole half of their body's not going to move. So that area cones down to a very small area. I mean, it's like, the tip of your pinky. So if you're off here by a couple millimeters, then that can be the difference maybe between paralysis and not. So this is one where I would look at, say, tell radiology in the text that within between, say, 1 o'clock and 3 o'clock, we're going to be coming down and need to do an intraoperative MRI. And in fact, as you're resecting, if you get to here and you say, all right, well, I'm near the middle cerebral artery, I know we're out. If I see ventricle back here, I know it's out. But this was the area that I was worried about. So then we go down to into the MR. In fact, there's still a little bit of tumor left. Most of the rest of it's out. The boy goes back to the operating room, and then we were able to just take that little bit out, knowing that it was right there. We do another navigation study. So all these patients get navigation studies, just about all of them. The downside of the navigation is it's done beforehand. So if there's a cyst or you've removed the bulk of this tumor, things start shifting. So then the navigation really doesn't help you much. That's why the whole point of the intraoperative MR to then kind of reassess where you are and starting over. And now here's a patient on top that I probably wouldn't have done intraoperative MRI, just again because of boundaries. Here's the 7th and 8th nerve, which does facial movement and hearing. It goes all the way up to the tentorium. Medially, once you kind of find the edge of the tumor along the nerve and moving back, you should be okay. Plus, on radiology, we knew this looked like a high-grade tumor. It was actually done in an outside institution that has intraoperative MRI, the standard intraoperative MRI. But for whatever reason, here's all the tumor that got left behind. I don't know whether they did the intraoperative MR and felt they couldn't get it out or misinterpreted or what happened. But there's a considerable amount of tumor left. So just having an intraoperative MRI doesn't guarantee that you're going to get it out. So they came actually to see Dr. Phillips' team. The decision was made, the best thing to do is to take it out. And so we just went back and, again, went down, dissected, found the 7th nerve, went all the way up to the tentorium, and were able to take it out. Actually had a pretty nice plane. And with no deficit, actually, we just did this case this week, in fact. So at the end of the day, right, there's no substitute for neuroanatomy. So intraoperative MRI certainly helps, but there's certain areas there where knowing that it's stuck to an artery or a nerve, you don't need an intraoperative MR for that. You need a surgeon who's going to be able to take it out without injuring the patient. But real-time imaging is safe. There are several studies looking at it. And once you do it and get it up and all the equipment's right, that in fact it can be done safe. And low field and high field both are beneficial. I think the low field is more for the cysts and placement of catheters. And everyone's kind of moving towards these higher field MRIs just because they're much more accurate. And building the rooms to accommodate outpatients and inpatients when it's not being used in the intraoperative MRI is some way to kind of help diffuse the cost. With the low magnet, you would never want to scan somebody as an outpatient with the low magnet. And despite the high costs, it'll probably continue because that's the best thing we have here. Hopefully sooner or later, a new technique will come up that'll be easier, faster, and at least as accurate. Ultimately, hopefully with all the research that's going on, we won't need to do surgery, period. I mean, that really would be the best thing for everybody. And with that, we'll stop. And this is my little girl.
Thank you. So we've heard about surgery, chemotherapy, radiation therapy, and Wendy Hobby is a nurse practitioner who has been involved in taking care of these kids who have received all this treatment for many, many years. It's a great pleasure for me to see Wendy again. We greeted each other a little while ago by saying, well, I haven't seen you in 100 years. So we were in the same circle years and years ago when we were treating the children. And now that the treatments have been successful in terms of managing and even curing the tumors, then what? So Wendy has been involved in the development of cancer survivorship programs and is in fact the Associate Director of the Cancer Survivorship Program at CHOP. She's been involved with this practice for over 30 years and is part of the initial team that developed the first comprehensive survivorship program in the country at Children's Hospital of Philadelphia. She has lectured extensively, published numerous manuscripts regarding outcomes of survivors of childhood cancer. She's the co-author and editor of 2 books that help to guide the pediatric cancer survivors, their families, and us, the healthcare providers. So it's a great pleasure to introduce Wendy.
Thank you very much for that introduction. I like to believe that survivorship is the ultimate goal for all of us. Whether it's chemotherapy, radiation, or surgery, all roads lead to survivorship. And so my hope is to give you a little bit of a snapshot of how we think in survivorship and what we hope for your children someday. So today what I want to do is just give you a little bit of background, very short. What are some of the causes of these things called late effects of therapy? talk a little bit more specifically about the endocrine effects and those specifically seen in children who have been cured of brain tumors. So what are these mysterious things called late effects? Late effects are persistent or adverse changes that are related to the disease process, the treatment process, or a combination of the two. They can be physical, psychological, or social in nature, and they can appear several months to years to decades after therapy has been completed. What are some common late effects of therapy for all children, not just children with central nervous system tumors? They would be things like growth and development, linear growth, is my child growing, intellectual functioning or cognitive functioning, sexual maturation, specific organ function, how is my child's heart working, their lungs, their kidneys, reproductive, their fertility ability, health of their offspring, and of course, one of the greatest concerns we have is the development of secondary tumors, whether they be benign or malignant. And certainly the psychosocial adjustment, the overall adjustment, and cognitive adaptation. When we look at survivors of brain tumors or other central nervous system diseases, there are many effects that kind of pop up in my practice. Certainly cognitive is one of the greatest issues. But later on today, you're going to hear a lot about the cognitive effects of the treatment that children undergo, so we won't talk about that. Certainly neurologic outcomes, whether it is related to surgery, radiation, tumor location, and certainly psychosocial effects. And you're going to hear from many wonderful speakers later on today. So what I thought I would do is I would cull down a little bit and speak specifically to the thing I think parents most talk to me about, which is my child's growth. And when I think about growth, I think about growth hormone deficiency and thyroid hormone deficiency. So this is my nice little picture here that just kind of gives us, I know there's a, is there a, really? I'm not getting the, there it is. Oh, it's little. Okay. So this is the hypothalamus, and it's connected by a little stalk here to the pituitary gland. And what I'd like you to think about is that the hypothalamus is kind of like the on-off switch. It has inhibiting and releasing hormones. It tells, it's the big boss of the pituitary gland. It tells the pituitary gland, release hormones, don't release hormones. So the reality is the hypothalamus gets damaged by radiation therapy before the pituitary gland does. But it really doesn't matter, because once the on-off switch doesn't work anymore, we have to step in and do our job. So again, we talk about the hypothalamus and the pituitary gland are in the brain. The hypothalamus, that on-off switch, is controlling a number of hormones, and we're going to focus on growth hormone and thyroid-releasing hormone. So the hypothalamus is the boss of the pituitary gland, and then it tells the pituitary gland what to do. And when we're thinking about dysfunction or the hypothalamic pituitary gland not working or an organ not working after therapy, like the ovaries or the thyroid gland, it can be two different ways. The damage can occur in the brain at the level of the hypothalamus and the pituitary gland, or it can happen at the organ. For instance, if you give a child radiation to their brain and their spine, the damaging effects can occur at the hypothalamus and the pituitary gland or the thyroid gland itself. So it's important that we distinguish which one of those effects are occurring, and that's just basically what I said here. So who's at risk for growth hormone deficiency? So certainly the younger the child is at time of diagnosis, the higher the incidence and the greater effect. Because again, if you think about a young child, they have the majority of their growth to go yet. So if we're treating a 4-year-old versus a 12-year-old, the impact is going to be different. Greater than 1800 centigrade of radiation, oh, press the wrong button. Can I go back one? Thank you. We used to believe that children were pretty safe somewhere around 2400, and we've found more and often that sometimes kids will begin to show at least partial growth hormone deficiency somewhere around 1800 centigrade. And surgery where the tumor is very close to the hypothalamus and the pituitary gland can also cause growth hormone deficiency. And when we're thinking and looking at a child for how well their growth is going, it's very important for us not only to think about the hypothalamus and the pituitary gland, but also to think if they got spinal irradiation. Because if they're radiated for the whole spine, that spine will grow less well than it would have had it not been exposed to radiation. So those are important factors that we need to keep in mind when we're looking at a child's growth. So a child who would present to us, or actually to any of the practices well before they get to us in survivorship, what we're trying to look for when we're assessing a child's normal growth is a child who is not in puberty. All the years leading up to puberty should grow somewhere between 2 and 2.5 inches each year. When they're in puberty, they should grow more like 3 to 4 inches per year. And it's very important that we monitor any child's growth who we're concerned about at least at every 6-month intervals. And it's going to be very important while the child begins to go through puberty that we watch when they begin puberty. Is it too early? Is it too, for a girl or for a boy? It's going to be very important because, again, every child grows about 2 inches, let's say, leading up to puberty. So if they go into puberty early, they're going to grow quickly, and we're going to be excited about that because we're thinking, great, they don't have growth hormone deficiency. But if it happens too early, they'll go through puberty, they'll get their pubertal growth, then they'll stop growing early as well. So our goal is to keep an eye on puberty as well as other factors. And nutritional status is very important down here. Can you go back one, please, again? I keep hitting the wrong button. Nutritional status is very important here because we do have a category of kids who don't seem to eat well for a variety of reasons. And again, I'm not so much worrying about on therapy. Most kids from all diagnoses don't eat great on therapy. So you don't have to worry about that if that's where your child is at. This is really much more long-term. So it is important that our children are eating well and gaining weight because if they're not eating well and gaining weight, they're not going to grow. So again, when I see a patient who comes into our clinic, what are the kinds of things that I'm looking for? I'm looking for someone who's beginning to cross in a negative way through their growth chart. So you've seen the growth chart. It's supposed to go like this. It kind of has an arc like this. It would have been smart for me to put a growth chart up here, but that's okay. And so what I'm looking for is even if I have a child who's all the way at the top of their growth chart and I start to see a downward arc, this is before puberty, that's going to be concerning to me. Again, we talked a little bit about puberty. If a child goes into puberty early and all of a sudden they start growing well, I have to be mindful of, is this happening at the right time? Because if it's happening too early, it's almost like it's fooling me into real thinking that the growth hormone is doing just fine. We also are looking at growth factors. We draw growth factors, a serum study, on every child who is at risk for growth hormone deficiency. We look at growth factors, we look at thyroid factors, we make sure that we look at what we call their bone age. What is a bone age? That's actually, we take a little x-ray of the child's hand. And all of us kind of have 2 ages, our chronologic age and our bone age. And we want to make sure that the child's bone age is either same as chronologic or behind. If it's advanced, that gives us concern because we want to make sure that we're capturing as much time for growth as possible. So again, we looked at, I was talking about this precocious puberty or this early puberty. Who's going to be at most risk? Well, children who have had brain tumors are at risk for that, optic gliomas, other disease. I just threw another disease in there just to realize that there are other children as well who also deal with that. And again, somewhere around the radiation dose of about 1,800, we begin to be very vigilant about monitoring for precocious puberty. So whenever I'm thinking about growth, the other thing we always evaluate is the thyroid gland. So the thyroid gland, really, I like to think of it as the little engine that could. So that's kind of keeping your metabolism going. But if you have a child who has hypothyroidism or an underactive thyroid gland, again, that would be somebody who might begin to not grow well. So we can't just think about growth hormone. We also have to be thinking about the thyroid gland as well. And again, who's going to be at risk if the thyroid gland is in the field of radiation? Now, if a child only gets cranial radiation, probably the thyroid gland is okay. But when we talk about doing radiation to the posterior fossa, the back of the head, or down the spine, again, we know that the thyroid gland, unless it's the newest levels of radiation therapy that we have to offer, there is going to be a little bit of scatter where the thyroid gland is affected. So again, we make sure that we keep an eye on thyroid gland function as well. Now, secondary hypothyroidism, remember when I was talking about that the damage can occur either at the brain level, the hypothalamus and the pituitary gland, or at the thyroid gland. Well, this would be a situation where someone gets, let's say, 3,600 centigrade of radiation to their whole brain. The hypothalamus and pituitary gland might not be working, so that would be considered a secondary hypothyroidism. Again, it doesn't really matter where the damage is, where the cause is, whether the on-off switch doesn't work, or whether the thyroid gland doesn't work. We have a really good fix for that called Synthroid. We put you on thyroid hormone, and things seem to go much better after that. In general, we don't see children with full-blown hypothyroidism. Why is that? Because we're watching. We know that there's a risk, and so we're drawing studies, and so most times they're preclinical when we diagnose them and start them on Synthroid. So if you have a child who's been treated for a brain tumor, what are the kinds of things that you should be looking for? So parents really are the best informants. Anyone who doesn't listen to a parent is a fool, because you know if your child is growing or not. You're the person who's buying the pants, and it's the same size pants that it's been forever. Or their shoes. You haven't changed shoe sizes in 6 months or a year. Children are supposed to grow. You're supposed to be buying bigger clothes, and you're supposed to be buying bigger shoes. So if you're concerned about that, it's important that you bring that to someone's attention. If they're not gaining weight, if they're underweight, if they're really struggling to eat what you would consider regular meals. A lot of times it's easy when you have another child. Not that all children, even if they're both your children, are the same, but if you watch that they get full early, they don't seem to eat enough, they're not eating frequently enough, or they're not hungry, it's important that we get a nutritional consult to figure out how we can boost calories to help them grow better. If they're starting puberty early, so what does early mean? If a girl before the age of 8 is developing breast buds, and it's one of those things where, how do I know I'm pregnant? You know breast buds, so you'll know breast buds. Now, the boys are a little bit more complicated. If anywhere before the age of 9, a boy has his first sign of puberty, which is testicular enlargement, well, I don't think a lot of times boys are going to come down and tell you that they have slightly testicular enlargement. And somewhere around this 8, 9 area, the boys are starting to say, no, and they go running away. So that's a little bit more difficult to figure out if they have precocious puberty. But again, it's not only your job to be watching, we really should be the ones guiding and making sure that we're checking their testicles and making sure that they're not growing too early. And it's important that you guys know you're always part of the team. Now, the other thing that I don't have a slide up here right now for that I'll talk a little bit about is growth hormone replacement. I think that it is one of the most difficult conversations that I have with families because I hear a number of things. I hear, I don't want my child's tumor to come back because of the growth hormone, or I don't want another tumor to come back because of the growth hormone, or my child has already had enough. I don't want them to have something else. What I can tell you from over 30 years of experience is growth hormone is safe. We deliver it in a safe way. Are there risks? There are risks to everything. There are risks to taking too many vitamins, to taking an aspirin. But with the risk-benefit ratio, growth hormone is not just about how tall is my child going to be. Because many times that's what parents will say. I don't care. My child's alive. My child's healthy. If they're short, we'll deal with that. Growth hormone has many, many other properties, which are about bone density, like how strong their bones are, fat to muscle ratio, like is their body metabolizing things in the appropriate way. And even after you finish growing, some kids need adult hormone replacement so that they still can get growth hormone if their pituitary gland is not being told to make the growth hormone that they need. We all need growth hormone. Even at my age, we need growth hormone. So I think that it's very important, but it's always a family's choice, and it's our job to help educate you and answer your concerns and your fears about the treatment that your child's going to receive, whether it's surgery, chemotherapy, radiation, or growth hormone. And so I was just going to do that little bit of a snippet, and then I think we'll have a little bit of time for questions. Thank you.
So if you have questions, we're going to ask you to please step up to the microphone so we can all hear, and it is being recorded. So come on up with your questions. Oh,
One of the questions that we have, and probably a lot of people in the room, our son is a survivor. He's 2.5 years out. He was fortunate. Tumor type was favorable in prognosis, a germinoma. Location was not so great, left midbrain area. So he's still struggling with the after effects, and we think a lot of it has to do with the radiation, 25 doses, but, half were whole ventricular and half were at the tumor site. Whatever you can further describe about the effects of the radiation, that's what we suspect is causing a lot of the difficulties that he's still having a couple of years later.
Wendy, Peter? You go first.
Well, I'm going to start by saying our goal ultimately is not to use radiation, and to use, if we need to use as little radiation that we possibly can. I think that there are areas of the brain that are more sensitive to radiation effects and expressing them in terms of thinking and behavior than others, and it really, part of it depends on where specifically the radiation was given. I think that experts who are in the room, like Dr. Armstrong right now, can speak to some of the changes over the course of years that one may expect to see. Often, our biggest changes are in the first couple of years, and then we may see a period of a plateau or a period of stability. It's very difficult to say on an individual basis what to expect. I think that one of the things that's particularly important is to look for things that we can do things about. So just as Wendy has talked about, making certain that there are no endocrine imbalances that are contributing to some of these issues, making certain that we have done the best that we can in terms of defining what your child's strengths and weaknesses are in terms of thinking, and being able to work with the school system in order to formulate a plan for that. And if it's on an emotional basis, to be able to pull together the kind of supports that we see at CHOP in psychology to be able to address these. Because I can say specifically, in my own experience dealing with brain tumor patients, that often in the community, if you have a psychologist or psychiatrist in the community who's working with one of these patients, they say, "My goodness, I don't know what I would do if I were in your situation," which is not particularly helpful. But having both neurocognitive people, neuropsychology people, as well as late effects people to be able to guide you through this process.
I think Peter really touched on all the important points, and if you have more questions specifically about your child, we can talk during lunch.
Hi. I first want to say, Dr. Phillips, Dr. Storm, you've been wonderful in the treatment of my daughter. I'm a newbie. My daughter's in the middle of treatment. She just finished radiation treatment a couple of weeks ago. But it's a three-part question, so sorry if I'm lengthy. The first thing is, I love the proton therapy that CHOP has, or HUP has. The question is, though, it does tend to break down a lot, and unfortunately, during my child's radiation treatment, the last week, it did break down. For 3 days at the end of her treatment, she had photon therapy, and it was to the head. So that's a question on what are the side effects on a situation such as that to the head. The other thing is, my daughter was already diagnosed with failure to thrive when she was a baby, so she's very tiny. Growth hormone was mentioned before we found out that she had cancer. However, we were told about risks of breast cancer. Now, I don't know if that's true anymore. But the reason why I'm asking about this is, you had mentioned hormone therapy, and obviously now with radiation and the cancer that she has, that her growth is going to be even more impeded. And what do you do about a situation like that? She was diagnosed with 3 years. Her bone age is 3 years. already limited, if that makes sense. And the other question, the last one, is with endocrine. I don't know, when do you start testing the endocrine system? Is it, during therapy, after therapy, in between radiation and chemo? So.
Is this microphone on? Can you hear me? Okay. So you have really good questions. In the grand scheme of things, I wouldn't worry about those last 3 days of radiation. The bulk of her radiation was delivered in the other way. I wouldn't worry about those last 3 days. I don't even think that we would even calculate that out. So that I would kind of like put on a shelf and not worry about it. The fact that she has failure to thrive, I just hope that you have nutrition involved, because nutrition, right now, that's all you can do, is keep her as nourished as you can. She really can't get growth hormone until she's at least a year out from no therapy and everything looks terrific. So there's really, it's a moot point to even assess it at this point. So I would say that right now it's to get her through therapy and to keep her as well nourished as possible. And the fact that she has a delayed bone age is terrific. That's exactly what we want. That means we have more time for growth. So at this point, I think the most important focus is nutrition, 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 and finish therapy.
Could I just comment on two things? And I'm not trying to make excuses, but the issue of downtime on proton machines are universal. Okay? This is in Boston. This is at MD Anderson. This is in Gainesville. It's the problem with the cyclotron. And the cyclotrons are much more finicky for protons than they are for photons. And so in this best of all possible worlds, we would be up running, 24/7. It is frustrating and it is scary to be told that there's an advantage and your kid isn't getting it. Okay? Or isn't getting it 100%. However, that's kind of the state of the art right now, and there's nobody who's getting it differently. The issue with respect to when do we test for some of the endocrine issues, part of it's where's the tumor. So in terms of some of the tumors, we're testing for it right after surgery or right after radiation therapy. If the hypothalamus and pituitary aren't in the primary surgical area, we're testing for it at least yearly. But we want to be able to look for things that we can do something about. So the ones that we do things about up front are, as Wendy said, thyroid, are issues of cortisol and how the adrenal cortical axis works. And if there are problems with fluid balance that cause diabetes insipidus, that we are helping to manage that. So those are kind of tuned in really quick. Okay, thanks.
My situation is a little bit different. My son has not gotten any kind of treatment, and he was diagnosed last year with a JPA and an AVM. Now his AVM is very, very big, and I'm basically here just to find out, is this normal, this non-treatment that he's getting, because he already has hyperthyroidism. We are on the verge of the diabetes insipidus. I'm sorry if I'm saying it wrong. He's already getting Synthroid. I've watched my son from being a regular child to not really being able to do much of anything, and he's not even able to remember half of the things that he needs to remember. He couldn't even remember people that he just met over the summer. Is this normal? Is this the protocol that the doctors usually do with a situation where he has an inoperable JPA and an AVM, or am I at the wrong hospital? I came here for that because I can't see him like this anymore. And I feel like he's not getting the treatment that he actually needs to be getting, because there should be something more done. He was opened up misdiagnosed with a craniopharyngioma, and then turned around and was told after they opened him up that it was not, and it was a JPA. The JPA is sitting next to his optical nerve, and it is sitting right next to his pituitary gland. So they felt if he took it out, he would be blind, and he would have more hormonal issues. So all the late effects that you are describing, he already has without even the treatment. And I just came to find out if that's normal, if that's, I just need to know, basically.
So in terms of the AVM, we'd have to take a look at it and see, again, often like with tumors, you can take these things out. The question is, how big is it? Where is it? And what would be the deficit? The most very large AVMs we actually don't treat, and fortunately, it's one of those things where, like, the bad news is you have a huge AVM. The good news is they tend to bleed much less likely than the smaller ones. So the very large ones don't tend to bleed. So if they're too large to be, usually, at least the way we handle them, we first operate, and if we feel we can't operate, then we would do radiation, actually, with protons typically. If the proton therapy people think that it's too large even to radiate, then we do just kind of monitor them and say, look, this is too large. But again, the good news is it's not supplying, there's no brain that's getting supplied by the AVM, and we just hope it won't rupture, and the large ones tend not to. In terms of the pilocytic, it often depends on the chiasmatic hypothalamic gliomas, the size. We often can operate on them to either get a diagnosis or reduce mass effect. But you definitely cannot take it out completely by taking out the hypothalamus. Oftentimes, there's something called the mammillary bodies that are involved. And you mentioned some short-term memory. If the mammillary bodies are involved, you can have horrible short-term memory deficits from that. But overall, to make an ultimate decision, we'd have to take a look at the film. Often, we'll get the diagnosis if you think it's a craniopharyngioma, is it a hypothalamic glioma, is it a germinoma, to get the diagnosis, and then turn it over to oncology for some treatments.
Can I just make a comment here? We heard this morning in a very eloquent way from the mother of a patient that you need to kind of follow your head and your heart, and that I would urge you, because I think you have important questions, to seek other thoughts about this. There are circumstances in which we do sit tight with a JPA. If it's not growing, and if it's in a dangerous spot, and there are no new symptoms, we may just sit tight. So that's not necessarily a bad thing, but I think that in order for you to be confident that you are doing the best for your child, persisting and pushing is an important thing, and I'd be happy to talk to you about that more. Okay?
We have time for maybe 2 questions. We're going to start here.
Okay, mine actually is not a question. It's a comment that I want to pass on. I have a son who is a 20-year survivor of a medulloblastoma, and I'm really grateful for that. But seeing all the problems that he has and talking to a lot of other parents, I wish that with the team that there was also a component of a psychologist involved, because my son and many other of the parents talking about their children, these kids have a lot of social issues in terms of knowing how to read body language, knowing how to communicate with regular kids, and there's nothing that is given to you to help you work with that. It's kind of like you're out there and then you're fending for yourself. I think it would be great if there was some kind of group, or even if when they're in the hospital, if Child Life or when they had those activities going on, they could help them from the very beginning, start to know how to have those regular interactions. Because I've got a 26-year-old who is very lonely, and he would love to have lots of friends. and doesn't know how to do it. And when he was little, I could be there and I could say, hey, Daniel is a no-touch friend, so don't go near him. And that worked, but I'm not there when he goes and works at the movie theater to know which of those people there he can touch and which of those people he can, or which person isn't going to like his jokes and which person, isn't. So I think that's an important component now that these kids are living, which is awesome, to help them have a better life by helping to teach them those skills.
And I think that you'll hear in a little while, when you hear Iris Palton speak to this, and you'll hear other people speak in the afternoon, it's very clear to us that cognition has been affected, the way they think. And when you affect a person's cognition, all of those social cues, and we're getting better now that we have a larger body of survivors, of intervening earlier and helping families, and we're really grateful that you come here and share with us, because you help us learn on what we need to get better at up front.
But I'd like to reinforce also the problem that you're having in the 20-plus-year-old group is a very big problem. And that is irrespective of whether you were talking about late effects from cancer or some of my colleagues who have children with autism, that once you get past 18, many of the programs that are so strong and helpful kind of fall apart. So trying to get longitudinal support, lifelong support under these circumstances is a major objective for us.
I want to make one comment. As a board member of the Children's Brain Tumor Foundation, we have programs. The hospitals cannot and do not have the types of programs that you are interested in for your son, in terms of jobs, in terms of the social isolation that many of these survivors have. So I suggest that you interact with Wade, who's back here, and Stacia and Wagner, and they run these programs. And
Like in DC or whatever?
they're all over. They're all over. So I want to put a plug in for that, and thank you for your comment. And we have no more time in this session for questions. The panel will be hanging around a bit. I think you can ask your questions individually to the appropriate panel member. I want to thank you all for taking the time to do this. It was great, and great seeing you.